James Sutton. I'm a person in long-term recovery. My guest today is Dr. Edwin Chapman. Dr. Chapman is an addiction doctor, a doctor of addiction medicine, trained at Howard University, and does a lot of work in the DC area, as well as training, probably nationally. His resume was a little too long. He's had so many awards and he does so much great work that his resume was like about, as thick as a dictionary. So welcome, Dr. Chapman.
Thank you so much. It's a pleasure to be invited into your realm. And, we met at a community meeting, both involved in an extended effort of our day, because we know that we have to take it to the people.
Yes, yes. So Dr. Chapman, being into addiction medicine, one question I want to ask, a lot of people don't understand how we term addiction as a disease. So if a person's using different substances and it seems voluntary, how come we call it a disease?
So the way I look at it, we're all addicted to something, unless we're suicidal. Our bodies are geared to want to do certain things, and some of those things can be done in excess. But our bodies are geared to really look for pleasure. So when we talk about addiction, we often think about drugs or alcohol or tobacco, but one can be addicted to work, for instance. One can be addicted to shopping or addicted to money, just making money, as opposed to really looking for positive outcomes. So I think when we look at it in that manner, we understand that each of us has the capacity to become overzealous, so to speak, in certain aspects of our lives. So we have to modulate that. We have to control that internally. And sometimes we're able to do that by just altering our behaviors. But when it comes to drugs and alcohol and tobacco, those substances actually change the way our brains and our nervous system functions. So they're a little different in that they actually alter our neurological system.
Right. Okay. Thank you so much. Now, in DC and also out here in Montgomery County, we're facing what's been termed as an opioid crisis. I was looking at the numbers, and in Montgomery County, in the first 9 months of 2023, there was a total of 101 fatal overdoses of including all substances. But it's been an increase of opiates, cocaine, an increase in alcohol fatalities in Montgomery County. How does that correlate to DC? Is DC running like the same or similar?
Absolutely. The numbers that you described are parallel here in Washington, D.C., and actually across the country. And those numbers have actually been exacerbated during and after COVID. And a lot of it has to do with the way our bodies have reacted to isolation, for example. We're not geared as human beings to be isolated. We're actually programmed to be to work in networks or to work with other people or to communicate with other people. So COVID created a very unnatural circumstance, and that led to, in many instances, anxiety, depression, and people look for ways of relieving that anxiety and depression. And unfortunately, alcohol, tobacco, and of course, other drugs came into increased use.
Right. Yeah, the same thing. I I was thinking that because also domestic violence went up in Montgomery County because of the isolation. I know I work in the treatment center located in the county jail, right? And I was, observing how the treatment centers were confused. We had never had this type of plague before, so they weren't admitting people. So services were down. When crisis was up, services went down because providers didn't want to infect their staff and the clients that were already there. So they couldn't admit people until that was before the vaccine, right? So it was really a mess out here before the treatment providers figured out a way to, not put their staff too much at risk and at the same time provide the services. I'm sure it was a challenge in DC too.
Yes. So COVID uncovered many flaws or warts, so to speak, in our healthcare system. And we had to quickly adjust. And one of those adjustments was the increased use of either televideo or just telehealth, using the telephone to connect with patients. So there were some positive things that came out of COVID.
Right.
The increased use of telehealth really brought into view, and the payment system, the fact that there are other ways and effective ways of actually communicating with patients and expanding access to patients. A lot of our patients have difficulty getting to and from the doctor's office because of care activities or the cost. So we're really finding and learning that from COVID, that telehealth is an effective way of communicating. It's not perfect. Some people feel that it's not as good as face-to-face visit because you miss some of the body language, et cetera. But it certainly is better than not having any contact at all.
And I'm glad you brought that up, the telehealth piece, because, your practice, has integrated telehealth very successfully. I think it's more of a model. So can you explain a little bit about the services that you provide in Washington?
So to just back up a bit, I got involved in addiction medicine in the year 2000, actually running a methadone clinic, one of the 4 methadone clinics in the District of Columbia. And then in 2005, I had been certified for buprenorphine office-based practice, and through an opportunity with the DC Superior Court, a senior parole officer actually had an idea of using office-based buprenorphine for some of the returning citizens. And we started off with 5 or 10 patients, and that blossomed in the year 2010 to 100 patients. And then I subsequently went back to Howard University, worked the Department of Psychiatry and the Department of Community Health, because I said my patients need more than just medication. They need social services, help, housing. They also need mental health services. So we came up with this idea of actually converting my office, which is about 2 miles from Howard University Hospital, to electronic records, and then rewired the office and put in telehealth. So we were about five years ahead of the pandemic. We were already set for the pandemic, and little did we know that all of this was going to blossom into a real necessity. So we learned a lot, but it also helped us really change the way medicine is practiced.
Right. Yeah. I was, reading about your service delivery, and I was really impressed because I hadn't heard of any model like that, and with so much success. And I've seen some of your successes in the meetings that we go to, in DC. I've seen some of the people and know them personally. that you really helped, overcome their heroin addiction?
So I tell people that, I've been out of medical school for 50 years, but it was in the year 2000 in the methadone clinic that I really learned to practice medicine, because I really had to put together the social needs and the personal needs of people, as opposed to just treating high blood pressure and diabetes. And once you sit down and listen to the trauma, the stress that many people have undergone from childhood, and we're seeing that every day. The same pattern has developed. So when we look at our children today, these are not bad children. These are children that are in bad circumstances. And so we as a community have to really change the way we approach healthcare. And so this model that you're talking about is really a community-based model where everybody is a doctor, everybody has a role, and all of those connections have to be made in order for this process to work. So I think it's, in a way, it's God-given. It us to really practice what we preach.
Right, and I'm part of a philosophy in Montgomery County called recovery-oriented systems of care, and SAMHSA, has also, promoted recovery-oriented systems of care, and that's kind of what you're describing. That the onus is on the community. It's not the treatment center that cures a person. The person recovers in the community. They're only in a treatment center, for instance, a 28-day inpatient for 28 days or detox for a few days, but they recover in the community among us. So it should be the faith-based community, the social groups, neighbors. We, us who in the community, have to embrace people coming home from incarceration, and people coming, off of drugs and alcohol addiction. To support them in their recovery. They're our loved ones, our neighbors, So this is what we do at Tree of Hope.
So you described the fact that some of the people that we meet within our groups are actually patients of mine. And I tell you, they are the best people. People in recovery, I found, are the most humble, but also the most giving people, because they've been there. They've seen the worst of life. They're so glad to have people to understand what they've been through. But it also helps us as providers to grow and to really have a better understanding of humanity, and what that this could be. I could be in the same situation, or a family member could be in the same situation. So we would want to have the same reciprocal help.
Right. Thank you. Very well put. I think we're going to take a break right now for a public service announcement, and we'll be right back with Dr. Chapman.
I'm an ex-drug dealer, and I'll be your sub today. Can you see anything different as a pill?
No.
You don't know?
Fentanyl is being mixed into everything now. There's only one thing that will save somebody's life. That is naloxone nasal spray.
Fentanyl, it's cheap, it's potent, and it's profitable.
Why would drug dealers put a lethal dose of fentanyl in drugs if they know it's so harmful?
Really just all about the money.
I just didn't realize that one pill could change your whole life.
More kids should know.
Hi, I'm James Sutton. This is Road to Recovery, and my guest today is Dr. Edwin Chapman. So Dr. Chapman, we were just talking about how the community, the recovery really happens in the community, and it's all our responsibility to support those coming home, returning citizens, and those that are returning from being addicted to alcohol and other drugs. In Montgomery County, the group that I work with in Montgomery County is called Trio Hope, and we train peer specialists. We train people with lived experiences to become part of the workforce, to work in the hospitals, the jails, treatment centers, shelters, where those people in need could use someone who has walked in their shoes, you know. And I know in the group that we meet on Saturdays in DC, you were describing some of my friends that I grew up with that are in your program and it's successful. Do you want to talk about any of those successes?
So part of our model that we're working on is a peer support specialist model, where one of my patients who's actually in recovery and his wife are actually getting paid through a SAMHSA grant through one of the faith group that I work with, the Leadership Council for Healthy Communities. So they got a 5-year grant from SAMHSA, and they're actually able to communicate with my patients while they're in the office, while the patients are in the office, and they actually connect with them by Zoom from their home. And if we have a patient that needs insurance or needs housing difficulties, or just needs somebody to talk to because they're going through a stressful situation, we can connect them to them during office hours immediately. And once we make that connection, that peer support extends after hours. So they exchange phone numbers, contact information, and frequently the patients will contact them before they contact me. And you can imagine how that reduces the stress on me and our office. You know, they talk about provider burnout. This is one way that you can reduce provider burnout, because one of the reasons why a lot of practices don't want to treat patients with substance abuse is because of the added issues like the social service issues or mental health issues. But those burdens can be taken off and extended into the community with these support services. So it is it's been a revelation for me.
Right, right. And that's, you know, I love it. I love the recovery coach, the certified peer specialist, you know, community. And it's a new model. It's a new model. It's in a lot of the traditional clinicians don't understand it yet, how to make use of it. But if an agency can incorporate a peer specialist to their treatment team, it can really, it can reduce, you know, relapse, get more retention in treatment. You know, it's a win-win situation. You know, I've seen a lot of successes when you incorporate a peer specialist on your team. Now, let me ask you this. Oh, go ahead.
Yeah, I think just like we have the fire department, the EMS, the police, that we need to have a network of paid peer support specialists in our communities that are getting paid just like everybody else to get retirement, because they are critical in these days of increasing stress in our communities. And this is not going to go away. We are going to need peer support specialists forever, as far as I'm concerned. They are critical to connecting, finding patients, and really filling that gap.
Right. Okay. Thank you. And let me ask you this, because we could talk for 2-3 hours. You like, you know, you're like my Google on addiction medicine, right? So I got a friend in St. Louis, and he's promoting, you know, pretty much Vivitrol, right? Because it's non-addictive. But you've had so much success, replacing heroin with Suboxone. What do you like so much about? What do you like about Suboxone, or is it just that the patients like it?
So the fact that it can be prescribed in a private setting, in the doctor's office, it's you can get a week up to a month's supply of medication, as opposed to the methadone setting where you have to go every day. So this really frees the patients up. The other thing is that buprenorphine or Suboxone is what we call a partial agonist. So it's the risk of overdose on this medication is much less than methadone. Methadone is what we call a full agonist. So it's much more difficult to prescribe, and you have to really have added skills using methadone. But buprenorphine is very safe, and because of the way it works, even if people use opioids on top of it, it binds to the receptors so tightly that if you have a certain level of medication on board, it will continue to protect that patient. So it's just a great medication. And what we found is that with these high potency synthetic opioids like fentanyl, that we tend to have to use higher doses than previously recommended with Percocet or OxyContin or even heroin. These high potency opioids are 50 to 100 times more potent than morphine. So the District of Columbia now has 98% of our overdose patients who die have fentanyl in their system. And in the past month, I've tested 25 patients for xylazine in addition to fentanyl. So xylazine is an animal tranquilizer. The street name is Trank. Many people are familiar with it from hearing about it in Philadelphia. It causes severe ulcers and even amputations. So our drug supply is so much more dangerous than even 5 or 10 years ago, and that's because these drug cartels are actually poisoning our communities.
Wow. Now let me ask you this in terms of saving lives. I know I've been doing Narcan trainings for quite some time. Before COVID, I was even training in Montgomery County. And since we started making Narcan available, the overdose fatalities decreased in terms of they were overdoses, but we saved a lot of lives nationally by the use of Narcan. Now, how is that? Is that still effective with the potency that you see in DC now?
So one of the things that we've noticed, we actually, the Narcan that is typically prescribed over the counter is 4 milligrams, and it's in the nasal dispensers. For a long time, I gave talks saying that the dose should be doubled, but in May, a new medication called nalmefene, or OPVEE, OPVEE is the brand name, is in the same kind of dispenser, but it's a different medication, but it's also an antagonist that works faster and lasts longer than Narcan. So I think we're going to need to see a shift from Narcan to some of these more potent antagonists like nalmefene. And I understand that there's some other antagonists in the works being tested right now. I'm not familiar with the names of those, but again, these high potency drugs that are being put on the street poisoning our communities means that we're in a very dynamic situation where we have to adjust as providers likewise.
Right, right. Now I know pretty normal in Montgomery County. I've seen police and the even in the jail, we've used four. We use four Narcan sprays to bring a person back because of the fentanyl is so strong. You know, you have to use four, and a lot of people won't have four on hand. You know, they got.
And I was faced with that 3 times last year on separate. I had to use 6 in my office, and we were very fortunate because we had plenty on hand. And one of the nurses actually was at a point that she wanted to put the patient on the floor and start doing chest compressions. But by that 5th one, we saw a little twinkle in the patient's eye. So I went out and bought nalmefene. And from what I understand, I'm the first physician in Washington to have nalmefene in the office because I don't want to go through that again.
Right, right, right. Thank you. Yeah. So we only have a few minutes left. So I just wanted to give you an opportunity to mention anything that we didn't talk about that you feel is important, anything that you're passionate about that you want to share with the audience.
So I really think that the work we're doing, the work that you're doing, the fact that we're able to get out into the community and spread the word and really get people at the grassroots level involved so that they don't feel stigmatized about this disease process, and the fact that we need them at the table to help, and that we also need to look at employment possibilities because we have to expand our workforce. We're faced with the numbers that you described early on. We're being overwhelmed, so we need more people in this field of work.
Right, right. Thank you. And you know, we're having a difficult time finding clinicians that want to come and do you know, brick and mortar work. A lot of the younger you know, students, they can get paid by just doing telehealth, and we need boots on the ground too. Telehealth is great, but we need boots on the ground too. And you know, a lot of the people that have that kind of passion are retiring now. You know what I mean? They came from an era where we really like to be there, you know, face to face, you know, in a brick and mortar. And the younger, I don't know, you know, you're on house camps and the different campuses. Does it seem like the younger people are going for just the money now?
Well, I've been very fortunate to have students who are doing some research in addiction medicine to come out to the office. And again, the more we are able to touch them and pass on that information, I think mentoring is the key. You know, I'm 77 years old, so at some point in time, you have to pass on the knowledge and let them do the legwork. And that's where we are right now. But right. It is a challenge. But I think the young people are interested, and we just have to build on that base.
Okay, thank you. And I just want to mention in closing that I met Dr. Chapman at our meeting in DC, where we're working on community. We're actually working on violence interruption. So even though you're working, you know, with the addiction medicine, you're out there on the ground trying to help wherever you can. You know, making yourself available after all your work hours during the week. You're still there on Saturday, meeting with other community groups, faith-based groups, just concerned DC citizens on how we can reduce the violence that the kids are perpetuating on each other in DC. So, thank you so much for all that you do.
Well, thank you. You know, all of this is connected. The homelessness, anybody that's had difficulties, we just can't separate what's going on with the children from what's going on in the home, what's going on with employment. We have to look at this in a holistic manner.
Right. I think that's the key, holistic, right. So thank you again for being with us today, Dr. Chapman. This is Road to Recovery. I'm James Sutton, a person in long-term recovery. My guest today, Dr. Edwin Chapman, and I'll see you on the road to recovery.